A common clinical situation is of a patient walking into your practice requiring a prosthesis, and there does not seem to be adequate crown height for you to be certain of the fact that your prosthesis will stay put and not keep dislodging. Hi friends, this is your host once again, Dr. Moez Kakiani, a prosthodontist from Mumbai, India. In this video, I will help you understand of the different options that we as a clinician have to manage patients who come in with what is called as SCC, that's a short clinical crown. A short clinical crown by definition is one where in less than 3 millimeters of vertical tooth structure is present after the tooth has been completely prepared. Now let's imagine we have a patient who requires a posterior crown and there is not adequate amount of tooth structure present vertically. So what all can I think of in a chronological sequence? First, the moment I have a tooth like this, I will think in terms of giving my patient secondary retention or resistance features. We all have read about a groove. A groove should ideally be 1 millimeter deep and 1 millimeter wide. This groove, friends, whenever preparing a crown, should be given on the proximal aspect, that's the mesial and or the distal aspect, because usually a crown tends to tip off in the buccal or the lingual aspect. So what a groove does in such a situation is it decreases the path of displacement, thereby allowing the prosthesis to be held in position for a lot longer. On the other hand, if you are preparing the tooth for a bridge prosthesis, give the groove on the buccal and or the lingual, because in a bridge scenario, it's usually a tipping force that causes the prosthesis to dislodge along the proximal area. So a buccal and or a lingual groove provides for the necessary resistance form. Besides resistance form, of course, a groove also increases the surface area of your preparation and thereby adds more retention to your prosthesis as well. So just repeating again, friends, on a crown, give your groove on the mesial and or the distal. In a bridge prosthesis, give it on the buccal and or the lingual. So in my head, that's the first thing that I will do for a short clinical crown. Let's look at the second option that I have. Whenever I have a short crown, I will immediately think in terms of fabricating a CAD/CAM restoration for my patient. Why do I say so? Now remember, whenever you are doing a regular prosthesis which involves casting, there is a die spacer which is actually a paint that is applied onto the die. Now imagine you've given a groove and the paint has been applied. Inevitably, a lot of times when the paint goes into the groove, it tends to sag down, and as it sags down, it takes away a lot of the anatomy or the depth of the groove. What now happens is when the coping comes back to you, the coping actually does not kind of extend enough into the groove that you have given. This just defeats the purpose of giving a groove. The advantage in a CAD/CAM prosthesis, of course, is the fact that the entire die spacer is computed electronically and is uniform in thickness. Now we are not concerned of the groove being obliterated because of a physical paint, which is the die spacer. So that's my second thought process, a CAD/CAM restoration. Third, I will immediately think in terms of giving my patient a monolithic restoration. Simply put, friends, either a metal or a monolith or a full contour zirconia prosthesis. These kind of prostheses require lesser amount of reduction to gain the strength that a short clinical crown essentially needs to withstand the occlusal forces. Any multi-layer restoration like a PFM or a PFZ, it requires greater amount of reduction because of the fact that there are multiple layers in it. A monolithic restoration is more conservative, thereby does not require as much occlusal reduction and can yet provide the necessary function. On an average, about a 0.5 to 1 millimeter reduction over the occlusal is all such a monolithic restoration needs. So that's my third essential go-to option when I have a patient who has a short clinical crown. Let us now look at the fourth option. The fourth option could be, friends, a sub-gingival margin. I'm not an ardent fan of this. Having said this, you may extend your margin slightly into your sulcus. This just increases more, or rather provides you more vertical tooth band for retention and resistance. The problem, of course, in subgingival margins is it's difficult to prepare exactly without violating the biological width. Impression making can become a little difficult, and most importantly, cementation becomes a concern because it's difficult to control the gingival clavicular fluid in such a situation. My next thought process also here again goes towards the cement that I'm going to use. A resin cement offers greater amount of bond strength. So when I have a short crown, I immediately move away from a regular GIC to probably a resin modified glass ionomer, or ideally a dual cure resin cement. These cements provide for greater strength in bond and also predictability in a long-term situation. The next option that I have available to me, the last option, which is the sixth in this series, is a surgical procedure, friends. This is crown lengthening. If you cannot achieve adequate height, let's take away the gingiva to achieve adequate clinical crown length. So these are my 6 options, friends, available as a dentist to a patient who has a short clinical crown. Once again, I wish you enjoyed this video. Small tips that will help you in your practice. Do share with your friends. Until we meet again, bye-bye.